Good afternoon. I'm John Iskander. Welcome to the July 2013 session of CDC Public Health Grand Rounds. Continuing education credits for Public Health Grand Rounds are available for physicians, nurses, pharmacists, health educators, and others. For more information, please consult our website. Grand Rounds is also available on Facebook, Twitter, and YouTube. We have a new featured video segment called Beyond the Data, which we post on our website and on YouTube shortly after the session. Scientific articles relevant to this month's Grand Rounds are featured in this week's issue of Science Clips, which is produced and distributed in conjunction with the CDC Library. Please consult the Science Clips website for subscription information and article downloads where available. We wanted our audience to be aware of a special exhibit on cancer survivors currently at the CDC Museum through this September. This photo features CDC's own Denise Marshall. Her image and name are used with her permission. On the day of baseball's All-Star Game, we bring you our own All-Star lineup for today. We now have some introductory remarks from the CDC Director, Dr. Tom Frieden.
Cancer kills more young people in this country than any other disease. Every year, more than 1 million Americans are diagnosed with invasive cancer. Screening tests can help detect certain cancers early, making them easier to treat or cure. That's particularly the case for cervical and colorectal cancers, which often don't have any early symptoms. But too few people get screened, and that causes avoidable suffering and premature death. Public health agencies can increase cancer screening rates by working with state Medicaid programs and state insurance exchanges to help promote, coordinate, and monitor cancer screening. They can also convene providers, patients, community organizations, and others to develop community-wide programs to support patients. This approach can also reduce disparities in screening rates. Today, public health has a tremendous opportunity. We can offer screening to every person in the United States who needs it. Early screening is an essential life-saving tool in our fight against certain cancers. Let's work together to make sure that screening gets done and follow-up gets done as well.
Our first speaker is Dr. Otis Brawley.
Thank you. It's a true pleasure to speak here today. I especially want to thank the organizers of this event because this is a very well-run Grand Rounds. I am a cancer doc. I'm also an epidemiologist. I'm interested in outcomes. These are my disclosures. What I'm going to talk to you over the next 12 minutes about is screening. I'm going to define it, tell you its purposes, as well as talk about some of the principles and give some real examples in screening as we apply it to the real world. The aims of screening are primarily reduction in cancer-related mortality and secondarily reduction in cancer-related morbidity. Screening can cause interventions, both diagnostic and therapeutic, that can be harmful, and that's going to be a continuing theme throughout my talk. Always important in assessing a screening test is the benefit to harm ratio in the population to be screened. There are tests that have a significant net benefit, and I'm also going to talk about some tests in which the harms may very well outweigh any benefit. The best way to tell if a screening test saves lives is through a prospective randomized clinical trial where people are randomized after entry either to a screen group or to a control group that is unscreened, and their mortality is watched over time. This reduces bias. Bias is most reduced through randomization. There are also going to be some healthy volunteer effects because people who go into our screening trials tend to be healthier than the general population. One also has to worry about drop in and drop out. Drop in is when people who are in the unscreened arm decide to get the screening test. Drop out, of course, is when people who are supposed to be screened regularly decide not to get screened. We also have to be careful of randomization by census rolls, which has become incredibly important or popular, I should say, in Europe, where they take lists of men age 55 and above and randomize them to be screened or not screened in prostate cancer studies, for example. Another important principle is lead time bias. This is the reason why we do not look at survival as evidence of screening benefit. We look at decline in mortality and not survival, because lead time bias is simply someone gets screened and they're diagnosed earlier. They still may die at the exact same time if they had not been screened, as you see here. And the difference between someone who's diagnosed due to symptoms and someone who is screened and diagnosed is the lead time. Now, screening tests are actually beneficial when they have a lead time like this, and you also kick the time to death out further to the right. Very, very important in the concept of screening is an understanding of cancer biology, and that is length bias. If we actually take a large population and screen them annually for a specific disease, say for example breast cancer, or it can be lung or cervix cancer, or prostate cancer for that matter, the people who are going to do the best are the people who are screened at the initial screen, the downward click on the left there. The population that's going to do the second best is the population diagnosed at the second, third, or fourth screen. And the population that's going to do the worst is the population diagnosed in between scheduled screens. This is the concept that there is varying biological behaviors. More aggressive tumors are actually less amenable to screening, whereas less aggressive tumors, sometimes tumors that grow very slowly, can be easily picked up in screening. There's a slow-growing tumor that's called an overdiagnosis tumor. Think of cancer developing in an individual, and they are diagnosed due to screening, treated and cured, and they go on to die at a certain time later in life. But think of an identical twin, both genetically and environmentally, who develops cancer, is never diagnosed or treated for that cancer, but still grows old and dies of something totally unrelated to the cancer, never knowing that they actually had the disease. Now, these cancers that would not go on to cause death or overdiagnosis cancers are tumors that people frequently don't think about, but they do exist, and they exist in large numbers. Some studies estimate that 60% of locally diagnosed prostate cancers are overdiagnosis tumors. Other studies show that perhaps 50% of radiologically detected lung cancers and a quarter of mammographically detected breast tumors may very well be these overdiagnosis tumors. It's important that we actually talk about our definition of cancer, because that's something that needs to evolve. And that's one of the reasons we have this difficulty with overdiagnosis. Virchow, shown here, was a pathologist in the mid-19th century, and he and a number of German pathologists did a series of autopsies, did biopsies, H&E staining, and with a light microscope, they defined the profiles that we use today for cancer. Now, these profiles are still used today, despite all of our advances in diagnosis. Look at all of the things that we've developed over the last 160 years, to the point that today, in a hospital near here, a biopsy is being done on a 5 or 6 millimeter tumor in a woman's breast. The same H&E staining that Virchow used is going to be used. A 2013 version of a light microscope is going to be used to look at that biopsy, and the pathologist is going to say, this looks just like what Virchow said killed that woman 160 years ago. This fits the profile of cancer. What we desperately need today is a 21st century definition of cancer, moving away from the morphologic definition of cancer, because we do not know if that 5 millimeter tumor, which looks like cancer, is genomically programmed to grow, metastasize, spread, and cause harm. Now, that being said, there are clearly screening tests that have been put to study and have been shown to be beneficial at the population level, meaning that they save lives. And this is the focus of much of this Grand Rounds. There are some screening tests that have been found to be beneficial for certain high-risk groups. We'll have an example of that. And then there's screening tests where the evidence shows that the harms are clearly outweighing the benefits. The U.S. Preventive Services Task Force is an independent panel of non-federal experts in prevention and scientific review of medical evidence, and they are primarily responsible for providing screening recommendations based on public health considerations. That being said, well-designed clinical studies have consistently demonstrated mortality reduction for breast cancer with mammography and clinical breast exam, a number of studies for colon cancer, a number of studies for Pap tests. Note with the stars the studies that have not been shown to be beneficial with prospective randomized trials, but we still hold them to be beneficial. Recommended based on risk factor assessment for people at high risk is low-dose spiral CT screening. Let's talk now about colorectal cancer screening. Colorectal cancer screening is incredibly important because, as Dr. Frieden said earlier, a large number of lives can be saved if we simply did colorectal cancer screening in an aggressive, organized way. We estimate that 15,000 to 20,000 additional lives could be saved in the United States every year if the 40 to 45% of the American population over the age of 50 and under the age of 75 who do not undergo colorectal cancer screening by any recommendation right now were to actually start getting colorectal cancer screening and aggressive follow-up and treatment. Subsequent grand round speakers will address ways to address barriers to increasing screening rates. In the case of prostate cancer screening, 11 out of 11 prospective randomized trials have shown the harms of prostate cancer screening, meaning the considerable overdiagnosis and overtreatment with numerous harms to include fever and sepsis, mental anguish, poor quality of life. 2 of those 11 studies actually do show that there is a reduced mortality, a small reduced mortality due to prostate screening, but all 11 trials have methodological flaws. Today, many organizations recommend that men understand this and make an informed decision about whether they want to be screened. Chest X-ray screening for lung cancer in the 1960s actually increased survival and was thought to be a good thing. When prospective randomized studies were done, it was shown that it did not decrease mortality. Indeed, there was a trend toward an increase in mortality in the screened arm versus the control group. The National Lung Screening Trial, which was done by the National Cancer Institute in the early part of this century, randomized 54,000 people at high risk because of smoking and age, high risk for lung cancer, to a spiral CT or a sham chest X-ray. And this was done at 30 sites with expertise in lung cancer treatment. And after 10 years, it was demonstrated a 20% decline in mortality in the screened group versus the control group. Of the 27,000 or so people who were screened, this translated into 87 fewer deaths, but there were still about 350 lung cancer deaths. And very importantly, there were 16 deaths that had been attributed to interventions caused by the screening. In this high-risk group for lung cancer, the benefit-risk ratio was 5.4 lives saved for every 1 life lost. 87 over 16 is 5.4. The benefit-risk ratio in terms of putting people into intensive care units and having major complications was even lower, 2.7 to 1. Again, the aims of screening are primarily reduction in mortality, secondarily reduction in morbidity. Screening can cause harm, therefore the benefit-harm ratio of screening is always important, as is the risk of the population to be screened. And we desperately need a 21st century definition of cancer, a way that we can say to a patient, you have something that looks like cancer, but genomically we know it is not going to grow, spread, metastasize, therefore we need to watch it. Or you have something that looks like cancer, and genomically we know that this is something that we desperately need to treat, because if it is not treated, it is ultimately going to cause you harm. Our next speaker will be Dr. Rachel Ballard Barbash.
Good afternoon. It's a real pleasure to be here today and actually to see so many familiar faces and to follow on with the sports illusion. I guess one of my accomplishments in medical school was that I was a second baseman for an all-women's softball league, and we won our league. So just to give you a sense that we in fact are following that illusion. So I was asked what can we really learn from cancer screening in international settings? First, I think it's really important. Otis just finished an excellent overview and a discussion of some specific tests that have been evaluated by randomized controlled trials, but we really know that screening is a process. It's not just one test, and it involves the areas of assessing risk in individuals and figuring out who really needs to be screened, doing specific tests to detect cancer, and then doing a more extensive follow-up and diagnostic evaluation to understand if the abnormalities detected in fact are cancer, and failures can occur throughout that entire process. So what might we learn from some international models of innovation? And in specific, the question I was asked to think about was, how have public health approaches been used in other countries? So it's important, of course, to understand that other countries have very different healthcare systems, and for many of these countries, most of their organized screening programs have been organized as public health programs outside the context of routine clinical care. And because of that, they have very active and comprehensive data collection and evaluation systems, and they look at that entire screening process, and they have a goal and objective of quality improvement, quality assessment. They also focus very much on trying to identify and invite the relevant population for screening, to look at all the processes as well as the outcomes, both the near term and the long term. And one of the innovations that's happening now in many countries, particularly with electronic systems, is they are building timely and active feedback systems to personnel and facilities to help them improve quality. I wouldn't say on an immediately real-time basis, but on a very routine basis that allows people to change as they're providing care. I thought it would be helpful for the group to have an understanding about an effort NCI has been directing since about the late 1990s, the International Cancer Screening Network, and this was really initiated to help us understand if the promise of breast cancer screening that had been identified from randomized controlled trials was actually realized when it went into practice. It started with 11 countries, and we expanded this about 7 or 8 years ago to look at screening for multiple other cancers. It includes now 35 countries around the world. And the purpose of this effort is to use and compare data from organized screening programs, or in the case of countries like the US, national data on screening, where that screening may be opportunistic in many cases rather than organized, and to really develop the methods for evaluating the impact of these programs. While randomized controlled trials were a major progress in the last half of the last century, I think our progress for the next century is, in the next half of this century, is to really understand how do we use data from clinical practice. So you can see from this map that many of the countries that participate are predominantly from Europe and the US, some from Southeast Asia. There's very few in South America or Africa, in part because they don't have organized programs, and screening for cancer, other than some circumstances such as cervical cancer, has not been a major area of focus for those countries. I'm going to talk about two areas, cervical cancer and colon cancer screening programs, to give you sort of a sense of what we're learning from this international landscape of research. So in the case of cervical cancer screening, a comparison between the US and the Netherlands, it's important to look at the parameters that determine how these screening programs move forward. In the United States, the organization is through medical screening, seeing a physician. They're opportunistic, or in fact, the phrase that's used in most of the rest of the world is wild screening. And in comparison to the Netherlands, it's organized under a public health model. You can see similarly the differences in age groups in the US, much broader. They don't have upper age limits, more narrow constraints in the Netherlands, much more often recommended intervals until very recently in the United States compared to the Netherlands, and differences in reimbursement. One of the Issues that they move forward in many countries now that have organized programs is that they provide reimbursement for their cancer screening so that it's only within the context of organized programs. And we see how that shifts whether or not screening is received according to guidance. This slide about the number of lifetime Pap smears that a woman would receive if one followed different guidelines recommended are very important. The first line is for the Netherlands. So over her lifetime, a woman might receive only 7 Pap smears. In contrast, the range in the United States is huge across different guidelines, anywhere from about 16 to close to 50, depending on the groups that you look at. So we have 3 to 4-fold more Pap smears done in the United States, but our decreases in cervical cancer mortality between these two countries has been nearly identical. This same story has held in other areas of cancer, somewhat similar also, for example, in breast cancer. Moving on now to talk briefly about the organization and structure of the United Kingdom bowel cancer screening program. They implemented a public health model. It was based on evaluating data from randomized controlled trials and a comparative effectiveness analysis, and they selected FOBT for a narrower range of people than we do in the United States, for 60 to 69-year-olds, and if there was an abnormal FOBT, those people would be evaluated by colonoscopy. So they picked this regimen in part because they only move forward if they feel that they have sufficient resources to actually screen all of the relevant groups. It's not a wild screening approach that says, you know, whatever would be someone could pay for, but more to how does one cover the population. And their organization reflects a public health model. They set up hubs that cover a very large population, 10 million people in this instance, and those hubs manage that entire process of screening. Once they have an abnormal test, the people are referred to screening centers that are actually run by nurses, and the nurses do the screening evaluation and the screening endoscopy. So they spent a lot of time actually training nurse endoscopists before they started their program. In all of these organized programs, they do extensive data collection, and what do they learn from this data collection? So this is just one example of one of the efforts that they did. They were trying to track uptake in their screening program, and this round refers to the fact that people are invited, a cross-section of the population, and in this case, because it's annual FOBT, people are invited every year. So somewhat differently than some early work in the United States, it appears that women are screened at slightly higher rates than men with colon cancer screening. It's very similar to results in the United States. People who have a high social deprivation score that relates to a whole range of neighborhood and environmental context issues have much lower rates of screening, only about 40% compared to 60 to 70% with people who are at the high, who have many more resources. And similarly, if they look at specific racial ethnic groups, in this case, they looked at people, the percent of the population come from an Indian subcontinent, those where people came from areas where there were a high proportion of people from Indian subcontinent. Perhaps also these individuals had higher social deprivation scores. They had much lower rates of screening. And we know that people who do not respond to screening, and in this instance, when they looked at people who didn't respond to the first round, only about 10% of them ever came in to a future round. This is we have the highest rates of late-stage disease among people who have never been screened. So we really need to perhaps shift our attention to just getting people to screen more who are already being screened and focus on those people who never come in for screening. So I want to close with briefly talking about the provider participant systems and organizational factors that can improve uptake, and our future speakers will address this in more detail. We know that from many countries that people with higher SES in education, people who are white, older men in terms of colorectal cancer, and married people have an increased uptake. But we also know that there are a number of factors that can help to increase this uptake. If you look at the system level, having very specialized screening services and staff that are focused on increasing uptake, actually planning your resources and programs so that you will meet the anticipated design. There are a number of what people might call in-reach kind of efforts to really mobilize and train healthcare providers in terms of having them understand cues to action for targeting noncompliance, and as all things, giving providers report cards, training, and feedback really make a difference. And it's been well established that in terms of patients, our healthcare users, that reminder systems and intensive and personalized outreach and education really make a difference. So that closes my remarks, and we're moving now to Ned Kalange, who will address the next topic.
Thanks, Rachel. I'm thrilled to be here today to talk about the Affordable Care Act and how it's going to provide opportunities to improve population-based cancer screening. I think this is an unprecedented time for public health. I don't know if you've actually read the bill. It's only 973 pages, which is only 140 pages longer than Harry Potter and the Deathly Hallows. But it really has generated a lot of interest in public health, including this landmark report from the Institute of Medicine, Primary Care and Public Health, Exploring Integration to Improve Population Health. And it's interesting that within this report, they actually recommend making population-based colorectal cancer screening better by integrating public health and primary care. The report identified specific provisions of the ACA that could support this integration, and I wanted to just talk about a few of those. First, for those of you in local public health, you already know about the community transformation grants. So these are opportunities that local health departments have to apply, and some of you have, and some of you have been awarded, and some of you are still waiting, but to actually look at a population approach to your communities in improving health. The community health needs assessments, I always like to include that. Nonprofit hospitals now have to assess the needs, the health needs of their community as part of their community benefit. And they've realized, guess what? Local public health has been doing this for years, and many of you have already completed a recent evaluation. And so we're starting to see partnerships between nonprofit hospitals and local health departments. The Medicaid Preventive Services is an optional grant program that states and local health departments can apply for, and local health departments could actually either alone or in partnership with safety net clinics become Medicaid providers and really reach out to those hard-to-reach populations that we really need to include in order to improve population health. The next two, accountable care organizations and patient-centered medical homes, are looking for ways to better integrate care and then take care of an entire population. And I would tell you that I can't see that you can really include the entire population and be truly accountable without reaching out and including public health. And then finally, the last two, primary care extension programs and the community health care centers, are strengthening our primary care safety nets. And I think looking for partnerships, again, with local public health that has the experience and the knowledge about how to reach out to hard-to-reach populations is a real opportunity. There are specific provisions of the Affordable Care Act that I think can really push and improve population-based screening. For example, there's now first dollar coverage, which is no additional out-of-pocket costs for evidence-based cancer screening, specifically breast, cervical, and colorectal, that are based primarily on the U.S. Preventive Services Task Force recommendation. So these are the A and B recommendations that, like Dr. Brawley alluded to, clearly the benefits outweigh the harms. The ACA also formally authorizes the Community Preventive Task Force, which is a CDC-hosted program, and then directs both task forces to look for, quote, how each task force recommendations interact at the nexus of clinic and community. The Guide to Preventive Services, which is hosted by the Centers for Disease Control, publishes recommendations made by that task force, another independent, non-federal volunteer body of experts in public health and prevention research, practice, and policy. The recommendations for the community guide are also based on strength of scientific evidence, and I don't think it's any mistake that there are no fewer than 11 community-level interventions designed to increase participation in effective cancer screening. So, for example, Rachel talked about reminder systems, in-reach and outreach, remind the provider, remind the patient, prompt them to get services. Those are strongly recommended through the community guide. So you might ask, why should we take a public health approach to clinical preventive services? And I guess the answer is there's a problem we're trying to solve. It's clear that the U.S. healthcare system is fragmented with very little coordination. And we have tried to address that through what we have. For example, quality measurements, such as the NCQA HEDIS data set, have been shown to increase screening rates, but only in stable subscribers with very little population impact, manifested by the fact that our breast cancer screening rates have not changed appreciably since 2000. So why cancer screening in public health? Well, as Dr. Brawley talked about, cancer screening is different from other screenings in that it identifies preclinical disease. When we look at other recommended screenings, like screening for cardiovascular disease risk factors, it's critical the time that you will give the screening test, because early detection is time critical. We have to catch the cancer at the time where early intervention makes a difference. I guess the other point I would bring up in cancer screening is that there really are remarkable health disparities, especially in colorectal cancer. This is from the 2010 National Health Interview Survey and points out the disparities in the different forms of cancer screening. And you can see the real difference there in colorectal cancer. Those of you from other states know that these disparities actually vary by state. So in Colorado, we have more significant disparities in breast and cervical cancer than is manifest by the national data. All right, so that's a good reason to do cancer screening. Why public health supported population-based screening? Well, I think as the two speakers before me talked about, the benefits of screening are really maximized when everyone in the community participates. As Rachel talked about, preventable late-stage disease is more prevalent in people who don't get screened at all. So, for example, late-stage cervical cancers are found in women who never get screened, much, much, much less frequently in women who are getting every 3-year screening. The other point I would make is that we know that public health services can make major contributions to community-level prevention programs. I just picked one example from Colorado. Nearly 74% of our seniors 64 and older are immunized against influenza, data from the Colorado Department of Public Health and Environment. And then I point out that 80% of those vaccines are given outside of the medical care system, either in public health clinics or other clinics using a public health approach. We also know from Colorado's experience that we can do cancer screening. We have 10 local public health departments that provide direct services in breast and cervical cancer screening, funded by both the state and the National Breast and Cervical Cancer Early Detection Program, aimed specifically at low-income women. We also have the state-funded Colorectal Cancer Control Program, which supports CRC screening through a university-coordinated, community-located, population-based program. And some of our local health departments are looking at direct services for CRC screening in partnership with safety net clinics. So I want to finish with kind of providing you with a bold vision of the future for cancer screening, and just talk a little bit about the public utility model. So if you remember, the public utility model works to provide core services to this geographically defined population. And why not take that approach to cancer screening? Vermont's healthcare reform, through their Department of Vermont Health Access, provides kind of an example of how one state is doing that. So through a health department originated program, they're providing chronic disease management, behavioral health, and wellness and preventive services throughout the state in kind of this public utility model. I believe that supported by the provisions of the Affordable Care Act, the future of cancer screening may well see the development of screening as a public utility that provides population-based services and a remarkable improvement in overall population health. So I thank you for my time with you today, and I'd like to turn things over now to T.R. Levin, who's going to talk about colorectal cancer screening at Kaiser Permanente.
Good afternoon. It's also my pleasure to be here with so many familiar faces in the audience. I'm Dr. T.R. Levin. I'll be presenting our experience in improving colorectal cancer screening at Kaiser Permanente in Northern California. Before talking about our screening program, it is worthwhile to review some of the evidence about the value of the fecal immunochemical test, or FIT. I also review how our screening program is structured and review some of the patient outcomes that we've seen since we've been increasing screening rates. In deciding between various screening tests, an important consideration is which test will patients do, and the best test really is the one the patients will do. The FIT, or fecal immunochemical test, uses an antibody specific for human hemoglobin, while the guaiac FOBT uses a chemical reaction. Multiple studies summarized here indicate that patients are much more likely to comply with FIT testing when compared to guaiac. The value of increased adherence was demonstrated by the Barcelona randomized trial comparing FIT and colonoscopy. While adherence in both arms of the study were low, the adherence with FIT was significantly higher than with colonoscopy, leading to more cancers being detected in the FIT arm. The adenoma detection was lower in the FIT arm, but these results reflect only one round of screening. The participants in the FIT arm were due to have 4 more rounds of biennial screening in which their adenomas may have been detected. Giving further evidence of the value of FIT as an alternative to colonoscopy, John and Nadomi did a study in the federally qualified health centers in San Francisco. Providers were randomized in 3-month blocks to offer either colonoscopy alone, the guaiac FOBT alone, or the choice of the 2 tests. Offering only colonoscopy resulted in significantly lower adherence with screening compared with offering either FOBT or a choice of colonoscopy and FOBT. As background, the Kaiser Permanente Northern California region extends from Santa Rosa in the north, Fresno in the south, San Francisco to the west, and Sacramento to the east. We currently have a 46% market share, and our patients are generally representative of the surrounding population, with the exception of the extreme highs and lows of socioeconomic status. Our colorectal cancer screening program consists of both an outreach and an inreach component. Outreach refers to the mailing of test kits to everyone who's coming due for screening. Inreach refers to the electronic systems that prompt support staff and physicians to remind members that are coming due for screening and distribute test kits. We also use electronic systems to track patients who are FIT positive to ensure that they get their follow-up colonoscopies. Our outreach program begins with identification of the population that is eligible for the HEDIS measure, men and women aged 51 to 75. The electronic databases are reviewed to identify who is overdue or coming due for colorectal cancer screening this calendar year, as noted, and at the noted screening intervals. A sample of approximately 13,000 or more members are mailed test kits each week from January to September. We use a vendor to assemble the test kits on demand, and after using demographic data that we upload using HIPAA-compliant FTP site. We use the Aiken test kit, which is a single sample test with a cutoff of 100 nanograms of hemoglobin per milliliter of buffer. The outreach process is a shared effort between the regional program of mailing, including a pre-letter, a test kit 1 week later, and robocalls and reminder postcards. Local teams at each medical center can then send secure messages using our electronic medical record and make phone calls using medical assistants. The kits may be distributed at clinic visits or during the fall flu shot clinics. We have several reports and reminder systems that we work with to help move the work forward. We report to each medical center monthly information on their screening rates, the access to colonoscopy, colonoscopy productivity, and also adenoma detection rates among the colonoscopists. At the point of care, the healthcare team can see a preventive health prompt, which will be revised into an improved population reminding, outreach monitoring, and patient tracking tool. We report the rate of follow-up of all of our FIT positive patients, and where patients are in the outreach process. And we also are tracking cancer incidence and stage using our cancer registry. Over time, we have seen significant improvement in our screening rates as measured by the HEDIS quality of care measures, both for our Medicare and our commercial members. As you can see, the screening rates started increasing in 2007 as our outreach program ramped up. Before starting outreach, our commercial screening rates were approximately 40% and well below the 50th percentile nationally. As the screening program has matured, we have seen higher screening rates and are now above the 90th percentile, with performance approaching the national high-performing health plans. The result of this is that, as in every screening study or effort, when screening rates increase, there's an increase in diagnosis of prevalent cancers. As our screening rates started to increase in 2007 and 2008, we did see an apparent rise in colorectal cancer incidence. With subsequent rounds of screening, as precancerous polyps have been detected and removed, we've started to see a decline in cancer incidence, and we're tracking survival as well. We have successfully increased screening rates by taking the approach we use in our system for all population care initiatives. Leaders throughout the organization are committed to the goal of improving colorectal cancer screening rates. As a medical group, we set targets for our population screening rates prior to the start of every calendar year. Our incentives are aligned. Each medical center has a portion of its operating budget released each month based on performance on the various preventive health targets. And this also represents a true collaboration between primary care and specialists. There has been a concerted effort to monitor and expand colonoscopy capacity, and we use a mix of tests, allowing primary care providers to refer patients for screening colonoscopy and actively outreach with FIT. Most patients are screened because of FIT, but a growing proportion are screened by colonoscopy. We use our organized systems in both outreach and inreach to leverage our support staff to provide education and encouragement. And results are monitored, and local leadership as well as population care management and quality management staff are aware of how much additional work needs to be done that year. On a regional basis, it is our job to actively study departments and locations that are doing well and learn from them. And our work is not yet done. We still have an ongoing performance improvement opportunity in closing the gap between our Latino and African American members who have lower screening rates than our white and Asian members. At this point, I will turn it over to Marcus Plesha for his comments.
Well, thank you very much. I'd like to close by taking a couple of minutes to just describe a little bit of the current programs we have that are focused on cancer screening here at Centers for Disease Control. And then I'd like to describe some of the approaches we hope to take in the future to begin to move our programs more in the directions of some of the ideas that you've heard during the course of these grand rounds. The National Breast and Cervical Cancer Early Detection Program is CDC's core cancer screening program. And this program, since its inception, has really been designed to reach and provide services to women in the United States who don't have health insurance. As you can see from the slide, the reach of this program has really been quite significant over the last 2 decades. But equally important, we're very proud of the fact that not only have we been able to reach a lot of women with these programs, but these are women who are generally from very underserved communities, and we feel that the National Breast and Cervical Early Detection Program is probably one of the core reasons why over the last 2 decades we've been able to close some of the gaps in screening disparities across our different populations. In addition to significant reach, our screening programs at CDC also, I think perhaps even more importantly, have really substantial capacity. You see from this slide, we fund every state in the United States to provide screening services. We fund 11 tribes, and we fund 5 territories. And each of those health departments then has an extensive network of clinical providers they work with to provide these services. And so you see that from this slide. Our interest in the future, particularly as we begin to see implementation of the Affordable Care Act, is to think about how can we use this really substantial capacity we've built across the United States to begin to move the bar in some of these other kinds of approaches that are much more population-based and that are much more innovative. And so I'd like to spend the last couple of minutes talking about a couple of examples of some of the kinds of work that we're doing. Perhaps the best example of this new direction that we're trying to move CDC's cancer screening programs is the Colorectal Cancer Control Program. It's a program we funded about 3 or 4 years ago to look at the issue of colon cancer screening in the United States, where we feel that we are very much behind. And you see in the slide that the order of priority is reversed. We still provide funding to states to pay for some screenings, but the real emphasis of this program is in population-based screening promotion. And we've used evidence-based modalities amongst our different grantees, and our grantees have been able to work with this wide selection of different kind of clinical providers that we've developed through our other screening programs to begin to bring about some of these more organized types of approaches. Another example that I'm particularly interested in is collaborations between health departments and state Medicaid programs. I think everybody knows that in most settings, the Medicaid program is one of the places that some of the most underserved patients and communities reside in. And so a number of health departments are now looking at ways they can reach out to their sister agencies, their sister Medicaid agencies, and begin to look at ways to systematically reach this population. A good example of this is the state of Minnesota. CDC has funded Minnesota for what we think is a very innovative program with their state Medicaid program where Minnesota is using Medicaid claims data to actively identify patients who may be eligible for various types of cancer screening, and then really do very aggressive outreach and reminder systems and even incentives to try to reach those patients and bring them in and encourage them to participate in cancer screening. So I'd like to close by just summarizing a little bit of some of the ideas and the directions I think we can go as we think about new, more population-based and more organized approaches to cancer screening in the United States. And you see in this slide, really, I think the two different areas we can work in. On the right are patient-centered or patient-oriented approaches. On the left are population-oriented approaches. I think patient-oriented approaches to improve screening in the healthcare system are extremely important at the point that we are right now in U.S. healthcare. And these are certainly areas where I think public health departments should be very closely engaged with clinical practice in bringing some of these changes about. But ultimately, I think that the leadership role for public health, particularly for those of us who work in public health practice, the leadership role and the opportunity to really add value to the Affordable Care Act is in advancing some of these large-scale, population-based, organized approaches to screening, like you see on the left hand of this slide, and like some of the examples you've heard from our speakers. I think these are the roles that we have to begin to develop if we want to focus beyond established patient populations, and if we really want to look at how we're going to improve overall community health measures, the community health measures that we in public health are responsible for, and ultimately if we want to begin to turn the tide on some of these pernicious health disparities we see in cancer prevention and control. So thank you very much for your interest and attention, and I'll now be willing to open things up for questions for our panelists. Well, I'll warm people up a little bit and ask any of the panelists who want to respond. We talked about these new roles for public health. One of the interesting issues is, what are the skill sets that our public health workforce needs to develop to really be able to perform well in these kind of roles? Would anybody like to speak to your ideas about that?
Well, I'll start off. I personally believe that health education, public health education of the populace is going to be incredibly important. If the Affordable Care Act is going to be successful, if we're going to stem the tide of the obesity epidemic, and when I look at health in the United States, teaching people how to eat, teaching people how to exercise, and teaching people how to consume health care is going to be incredibly important.
You know, Marcus, I think the advice I would give local health departments of any size, and maybe it's not a skill set, it's a willingness to engage the medical care system. Integration with primary care can only happen if the two sides are actually talking together. And I think local health directors really need to take the initiative to find the leaders in clinical care in their communities, reach out to them, and look for those natural alliances. I think that's the only way we're going to see the integration. And so moving from the traditional things that you still have to do, right? Disease control, childhood immunizations, things that public health has always taken a role in, and thinking outside the box to cancer screening and chronic disease management. Looking for those relationships with the existing care system are essential. Reaching out to the Kaiser Permanentes, the hospitals, the other sources of care, that's how integration and the whole population improvement, you know, of a health standpoint is going to occur.
My learning over the last 5 or 7 years I've been doing this is the value of making an emotional connection to the work in addition to just the analytical, data-driven information that we were all taught so well in school. And if you really want to motivate change in people, they kind of have two parts. They have the analytic side, they need to know where to go, but you've got to connect with them on an emotional level to make them want to go somewhere as well.
Questions from the audience? Bob.
Thank you. So let me just say, first of all, those were outstanding presentations, and I really appreciate the common themes running across them. The questions that you were asking, though, Marcus, I mean, it really speaks to what is the opportunity to actually achieve the kind of quality in an integrated approach to screening that Rachel showed in that schematic. Presently, we have too much under-screening and over-screening. We have a follow-up that doesn't take place after screening takes place. We have a persistent problem that it's almost as if the market has to solve it, where there's low access to services, geographic access in some instances. And we're watching, for example, that we have not ideal access to GI services. Some women have to travel further and further distances to mammography. So I'm wondering, to a certain degree, how might the Affordable Care Act tighten up a lot of these loose ends?
Bob, I think it's a great question. You know, it's remarkable to me is all of the elements are in the act, but they won't happen by themselves. It's gonna take like the Craig Jones, you know, the reaching out and taking advantage and looking for the opportunities that CDC and CMS could take working together between the Innovation Center and the community transformation grants, trying to team up to address exactly those gaps in cancer screening that we could fill in with funding and opportunity from the Affordable Care Act. So I guess I want to make sure people know that the ability to do it is there, the opportunity and the time is now, and that there needs to be leadership and a few zealots out there to take advantage of it.
One more question back here.
The U.S. Preventive Services Task Force recommendations with respect to various cancer screening, the vast majority of the recommendations are for not screening. And Dr. Brawley noted the case of prostate cancer. There is a lot of controversy about mammography of women under 50 years of age, ovarian cancer screening. We have a number of organs that, you know, that should not be screened. And the conversation that I've heard is promoting effective screening. What I do not hear is effective ways of promoting not screening for cases that screening is injurious and has negative health outcome. And a good part of it is the issue of reimbursement. say a 70-year-old man under Medicare can go get screened for prostate cancer. CMS pays for it despite the U.S. Preventive Services Task Force recommendation giving a D recommendation for screening. So there is some sort of a disconnect, and I would love to hear some thoughts on the part of the speakers as to what are being done, like the Kaiser Permanente model. I wanted to ask the speaker, have you monitored the uptake of PSA testing as a marker that should not be universally used in the population setting of your institution?
I can tell you what we do at Kaiser. Certainly for the evidence-based screenings that are part of the HEDIS measure, we are actively promoting, advertising, reaching out to people. And for prostate cancer, it's very much of a shared decision-making model. There are some practitioners who are strong zealots of doing it and actually, try and talk very hard to talk their patients in. We have not tried to discourage them, but we certainly are not mobilizing all the systems. We don't have reminders for people when they come into the office to make sure that they have it done. But we're still in America, so people are allowed to.
But I get the problem I have is if the recommendation is against, why are we even promoting informed shared decision making? I mean, a D recommendation means that the physician should not even discuss it, should not bring it up.
Otis, this is your favorite topic.
Well, yeah, I've been dealing with this for about 20 years, and I think that people are now starting to understand that finding the disease early and cutting it out is not always the appropriate answer. And people are starting to understand that screening tests can be harmful. I was telling Dr. Kalanj, I thought that the Preventive Services Task Force recommendation is now viewed by most people as being a very wise one, now that just within the last 2 months, the American Urological Association has really tightened up their recommendations on prostate cancer screening. They no longer say all men should be screened. They say men aged 55 to 70 should be told about the potential risks and the potential benefits and encouraged to make a decision. So there is a change, a small change, but there's a change for the better within the medical community as we start learning that screening can be harmful. I'll also be forthright and tell you some people push these screening tests because they can make money off of them, which is unfortunate. And I will also utilize the fact that I am not a federal employee and tell you in 2000, in the year 2000, when the largest study run by the National Cancer Institute was a study to see if prostate cancer screening saved lives, the Congress passed a law declaring that PSA screening does save lives, and that's why Medicare has to pay for it.
So,
Matt, did you want to?
Yeah, I just have to add my own little 2 cents. So I think the first thing I'd point out is that the PSA adventure is an example of the dangers of premature acceptance. How many randomized controlled trials did we have before we actually started recommending mammography? We had 3. How many randomized controlled trials did we have before we started recommending PSA? 0. I'll let you talk about but we prematurely accepted it. It offered promise. It was very well socially marketed. And now trying to pull all that back in is really very difficult. The only other thing I'd like to say is that the most common used rating for the Preventive Services Task Force is the I, insufficient evidence, which is not a recommendation for or against, but a request, not for this room, but for our friends over at the National Cancer Institute, or someone to do research to fill in those gaps about whether or not the benefits outweigh the harms. And so it's a little different than don't do it. It's like we really don't know.
We have a couple of questions from people outside the room, and I'd like to move on to.
Yes, make one point that, in fact, you may need the most discussion about the tests that you shouldn't be using, because there is so much push to the population that they should do these things. So it's really trying to convince people that they shouldn't be doing these things. And so that issue, I think, of saying it really needs to be discussed is a key one.
It takes much longer for a busy clinician to have the conversation why you shouldn't do something than it does to just order it.
Questions from some of our virtual audience?
Yeah.
Yes, from our online and social media audiences. Given that there is now data supporting low-dose CT scans for current or ex-smokers aged 55 to 74 who have quit for less than 15 years, is lung cancer screening going to be included and paid for under the ACA for those people who meet all the criteria? And what will persuade other health insurance providers to cover it?
If I can very quickly, so we can get to more questions. The Preventive Services Task Force has not yet spoken about lung cancer screening. Some organizations like the ACS, the American Cancer Society that I work for, recommend informed decision-making for people who would have qualified for the trial. There are increasing studies, by the way, to show that lung cancer screening is more beneficial for people within that trial who were very, very heavy smokers, and not very beneficial for people who just had 30 pack years and just barely qualified for the study. So this is going to be a test for people at very high risk, and it's going to require informed decision making.
That's going to have to be our last question. I did want to say one thing. I really do appreciate our speakers who came out for this, and I want to say, because we had folks who are so esteemed in their field and who were willing to travel such a long way, we were determined to fill this auditorium, and we did. So thank you for those of you who came. Can you remind me of
Thank you all very much. Thanks to our speakers. For our in-person audience, there is a event at the CDC Museum. For the rest of our audience, we have an encore presentation next month. Our next live public health grand rounds will be in September. Thank you.